Mhm. Right. Thank you all for joining us. Thank you all for putting in your name. I see people coming in from Maine, Rhode Island, Michigan. Super cool. And someone also coming in from South Africa, which is even more cool. Thank you so much for joining us. We will get started. I just want to share some housekeeping. Please submit your questions in the chat feature as we go about with the webinar. We will also have allotted time towards the very end of the webinar to take in your questions. If then you would want to unmute yourself and ask your question loudly, feel free to do so. This webinar will be recorded. We'll send off the slides after the presentation, and the webinar will be posted up on our YouTube space so you can revisit the webinar too. Please continue to remain muted throughout the webinar, and after the webinar is over, we'll send a survey. It would be great if you could fill that out for us. Before we get started, I see some of the new members also joining in. For folks who've already been to our previous webinar, please put a thumbs up. And those who are joining us for the very first time, a little bit about the network. We are an organization which started in 2022 with the partnership of Bradley Hospital and Connecticut's Children. This was started because we saw a lot of kids entering the emergency department and kind of boarding there for days together. So we wanted to address this issue not just from a hospital lens, but more from a systemic lens. How can we look into children's behavioral health from state agencies' perspective, hospitals' perspective, providers, family voice, and youth voice? So that's been the mission for the network, and we serve as a connective tissue, bringing folks together from different states to discuss about various topics. Our last webinar was on CCBHCs and ACEs, and today's webinar is on IBH. We've got an overwhelming response with the registration also, and thank you all for sharing in so many questions. Um, Andrea, who will be serving as a chair, has also made sure that we looked into some of the themes that have emerged from those questions, and we'll try to address it through the panel discussion too. Stay connected to Network to hear more about our upcoming webinars, and towards the very end, I'll share some more insight into what's coming up next. With today's agenda, Andrea, who's serving as a chair, will quickly level set about what is behavioral health, integrated behavioral health, all about. And that then we'll dive into state presentations, Connecticut going first, then followed by Anita Morris from Team Up and Linda from Rhode Island. We will then have panel discussions for about 10 minutes and open the floor for Q&A for about 10 to 8 minutes. And it's now my pleasure to introduce our chair, Andrea Chu from the Hasselfield Institute. Andrea, why don't you go and introduce yourself and walk us through why integrated behavioral health is important?
Yeah, absolutely. Good afternoon, everyone, and welcome. My name is Andrea Chu. I'm the Director of Programs and Operations at the Hassenfeld Child Health Innovation Institute at Brown University. On behalf of myself and Ash and the entire network, I just want to reiterate and say thank you again, all of you, for joining us this afternoon. I would also just like to give a very special thanks to all of our speakers for bringing their expertise to today's discussion on integrated behavioral health. Each speaker will briefly introduce themselves before they present their slides. I have had the privilege of working alongside many of the panelists in varying different capacities, and so I am very excited for today's conversation. Ash, do you want to? Thank you. So integrated behavioral health is a model of care that integrates behavioral health services and primary medical care services into a single setting. We know that children's mental health and behavioral health are crucial for a child's well-being, their learning, their ability to thrive, and their overall development. Yet, oftentimes we hear so many stories from families, behavioral health services remain hard to access for many of these families, and they are often left alone to navigate a system of care that is overly complex, that is fragmented, and is also oftentimes disconnected from the places where families are already going to receive care. So I thought that today, before we start today's discussion, I'd like to ground us all by providing a brief example that illustrates the impact of integrated behavioral health. So imagine that a parent is in a pediatric clinic waiting with their child, Alex. Alex has been having a tough time lately and has been struggling in school. The nurse notices that Alex has scored high on their screening questionnaires for depression and anxiety. Alex's primary care providers there then refers Alex for an in-network therapist who can work with Alex further. After arriving home, Alex's parent calls the therapist and is informed that the next available appointment is not for 6 months. And so in the meantime, Alex's symptoms are actually getting worse. And so this is an unfortunate reality for many families, but it doesn't have to be this way. Instead, imagine that Alex walks into his pediatrician's office. They are first seen by their primary care provider, who this time brings in a behavioral health clinician who is also a member of Alex's care team at that clinic. The behavioral health clinician spends 30 minutes with Alex and his parents immediately after Alex's appointment. The clinician talks to Alex about specific behavioral health changes that can be made. They help Alex's parents sign a release of information so that they can more easily communicate and advocate with school on Alex's behalf. And they set up a follow-up appointment. Before Alex leaves the clinic, the behavioral health clinician then checks in with the doctor to update the care plan. And so I think that example really illustrates why integrated behavioral health is so important. When we have cross-sector collaboration between primary care, schools, community-based organizations, and families, we can identify concerns earlier, we can reduce stigma, we can improve coordination, and ensure that children receive the right support at the right time. And so Rhode Island, Connecticut, and Massachusetts, the states joining us on today's panel, they have all been making great strides around IBH. Even though each state has its own policies, its own challenges, its own programs, they all share the same goal, which is that of strengthening the pediatric and behavioral health workforce, improving access to behavioral health services, and creating a system of care that is grounded in health equity principles in order to support families and their children. Today's webinar is really an open opportunity to explore what's working, discuss the barriers that remain, and really learn from one another. So as Ash mentioned at the beginning, thank you so much for all of those that submitted questions. It was great to see that. Thank you again for being here. And so without further ado, I will turn it over to our first panelist, Daley and Keri from Connecticut.
Thank you, Andrea. Hi, everyone. My name is Daley Gay. I'm the Clinical Integration Specialist at Connecticut Children's Care Network for Connecticut Children's. And I'm presenting today with Keri Herlan. Keri, I'll toss it to you to introduce yourself really quickly.
Yes, I'm Keri Herlan. I am the Program Director for Integrated Care with the Village for Family and Children, and I have worked closely with Daley on this.
Okay, we can go to our first slide. Thank you. So just a really brief overview of what the Village and Connecticut Children's have partnered to do and how we're doing integrated behavioral health. And like I just mentioned, we partnered with the Village for Families and Children to do integrated behavioral health with the mission statement that you see on the screen there on the left, specifically for the providers in our clinically integrated network. So these are independent offices that are independently owned and run, and we partner with them. They participate in our value-based contracts, and now we are also offering them integrated behavioral health services. We've been doing that for about 1 year now. And throughout that year, we have launched 5 different locations. We have 1 social worker in each of those locations. And across the board, that's 30 to 31 primary care providers. In that 1 year, everyone's launched at a different point. So they've all been operating for different lengths of time. But collectively, we've had over 2,800 visits. And that's about a 20% new patient rate, which is pretty good as an average. Some practices are a little bit higher than others, which we think we anticipate a little bit. We've seen almost 600 patients and their families, which is about half of the patients that have been referred to those social workers. And then it's a very collaborative model. Integrated behavioral health is collaborative by nature, but our model is particularly collaborative in the fact that there's a clinical aspect to it, but also an administrative. And I'll talk a little bit more about the lessons that we've learned from that degree of implementation, the training, the EMR scheduling, even referral processes. But first, I'm going to pass it back to Keri to talk a little bit more from the clinical side and what we do on that level of collaboration.
All right, if you don't mind moving to the next slide, we have a few things listed on there. So like Daley said, we do have a social worker placed in each of these offices, and they're able to provide real-time consults and warm handoffs. So the clinician for most of the practices has their own office, and the staff there know where to go to get them if there is a kiddo who is either in crisis or potentially is a good candidate for a referral. So the physician can go and get them and bring them in, and that safe person, the pediatrician, is able to introduce the family to the provider. And so there's a safe place, there's a safe person. It reduces a lot of barriers to care. It's very, very collaborative. And there is that shared EHR, which is a good and an area of struggle that I think we'll talk about a little bit. There's targeted screening and assessments. Pediatricians use some standard assessments and or screeners rather, and the LCSWs are able to use them as progress monitoring and to put those in the medical record system so they can see progress over time, and helps us identify who might be a good candidate for care, which aligns pretty well with the universal behavioral health screening that the AAP, the ACA, and PCMH standards have determined. And we also utilize, outside of like a medical screener or a behavioral health screener, we do satisfaction surveys with the pediatricians and the families as well, which gives us some good information. And that's where our quotes below we were able to pull from there. Crisis intervention and management, that is a huge strength of having the LCSW on site, is if there is a kiddo who's having a hard time, they can go and pull in the behavioral health provider, and they're able to model skills, both for their parent, for the kiddo, for the pediatrician, to help them manage similar situations in the future. Case management support, there's lots of outreach in the community. There's care coordination to help on another level reduce barriers to care, food insecurity, transportation, along with like academic advocacy, attending PPT meetings. There's practice and provider education. The modeling is one piece of it, but the social worker can also provide trainings on site that can be specific to what the practice might need. There's lunch and learns, there's provider meetings, all staff meetings where little tidbits can be shared. And then we do referral refreshers, often to help pediatricians know that there's a broad spectrum of presenting issues that are appropriate for our model of integrated care. Takes me to the last one on here. So there's the primary care advantage, where families, that's their go-to, is to go to these practices, these safe places, and talk about the concerns that are happening. And about 50% of medical appointments have a behavioral health component. So it makes sense that there's a clinician there on site to be able to help with that. And they brief, goal-focused, evidence-based interventions, and there's a whole spectrum of presenting issues that you might see more traditionally in outpatient, but have more of a health behavior focus when worked on in integrated care. And those are two quotes, like I said, of two of our pediatricians. Dr. Hack is awesome. The greatest thing that's ever happened to our practice. He likes to fluff us up a little bit. But Daley, I'm going to pass it over to you to go over the next slide.
Thank you, Keri, and thank you for flipping aside. So like I mentioned on my last slide that I was, well, I guess not the last slide I was speaking on, we have learned some things throughout implementing our model into 5 different locations. And I've put 3 of the biggest ones. There are more, but there are 3 big ones here that we think would be good for us to talk about in a setting like this. So the first one is identifying our champions early. we have noticed that the practices that are most successful or that become successful quickly after implementing, after they go live with their services, have a really motivated physician leadership, motivated to succeed in the program and the targets, but also motivated to do the clinical collaboration. They motivate their peers, they motivate their administrative teams, and it helps not only with the education that the clinicians can provide throughout the term, but also when we're doing education beforehand. What does it look like? How do we refer these patients to this new person in our practice? And then really reinforcing that responsibility matrix, which gets me into my next point. We learned that we need to establish the framework, the processes that are involved with this early and clearly, but also very clearly establish where it has some flexibility. Because along with the motivated physician leadership, we want the practices to feel like they own this. It's a big collaborative project. There are lots of people involved, but having them feel that level of ownership and being able to adjust the model where it can adjust to their own setting, to their families, to their patients, to their practice, really, I think, drives success here. So we do that in a couple different ways. We have a variety of implementation meetings with clear agendas, clear content. That way we're communicating everything we need to, giving them the detail that they need, but in a clear and concise way. So we're learning one thing at a time. Process checklists so that after we're all done, you know that you have to do these couple of things, and this is how our workflows work. And like I mentioned, the specific build to fit, where it's flexible, where they can really personalize the process, and allowing them to do that personalization with things that they think about. So how do we communicate to referred patients? How do we do our warm handoffs? How do we talk to each other to tell each other that we need a warm handoff done? That kind of stuff we really encourage early, and that ownership, like I mentioned. We also focus a lot on the communication, but I think I'm going to let Keri talk about that one a little bit because it has a lot to do with the clinicians on site.
So there's a couple ways that we kind of see communication happening. A lot of it, if I was to talk about kind of clinically the case reviews, there's the clinician is working with me as their supervisor, with their peers, with the providers and medical staff, participating in rounds. We also have quarterly meetings where some of these cases are discussed, but on site, it might be a drive-by, it might be stopping into each other's office and working together. This is collaborative treatment planning. So the more that the clinician is able to work with the providers who are touching the kiddos' lives, the more comprehensive the treatment plan and more appropriate it's going to be for the families. We have decided through trial and error that weekly huddles are very helpful, and these have a little bit more of an administrative or operational way of supporting the practice and families, because families are sometimes they need support with registration and some other things, and we're able to support the practice and helping families with that. So communication wise, internal communication systems like the electronic medical record system, having that be shared is, I guess, one other way that communication wise we're trying to navigate. It is shared, it is, but we have a dual. So the practice has their own, and then with Connecticut Children's, billing goes through them. We have a separate one, but fortunately, the providers have access to Epic, which is the electronic medical record that we utilize. And so there's a lot of everything the physician has access to. They can see all the information about what was worked on in progress. And one of the last pieces would be parent and family resources. Mentioned before, there's a lot of case management, care coordination type pieces. It's not always directly with the family, though. The clinicians work hard to compile some strong and a very comprehensive list of resources in the community for maybe what are the food pantries, if we're going to talk about care coordination, what are some domestic violence resources in the community, what psychiatrists are taking patients, and compiling that so that it can be a resource that the practice can just give out to families. And the clinician is always building on that based off of the need of the practice.
I think that's it for us. Thank you.
Thank you, Daley. We can now go over and have Anita present about Team Up's work.
Thank you, Ash. Very nice to be here today. I appreciate it. Anita Morris. I'm a and I am the executive director of the Team Up Center. We are located at Boston Medical Center, so in Boston. Happy to go forward on the slides. So I thought what I would start with is just giving a little bit of a background on Team Up. We began back in 2015, so just over 10 years ago. And really what Team Up does is support pediatric practices, primary care practices, to kind of implement and move to a full spectrum model of integrated behavioral health care. So when we began back in 2015, we collaborated with 3 federally qualified health centers really to develop the model. And kind of every single piece of the model, which I'll go over in the next slide, was really created in collaboration with those original 3 federally qualified health centers. We intentionally were working with FQHCs really to ensure that as we developed the model, we were developing a model that would live and breathe in federally qualified health centers long after the term of initial implementation, the kind of focused implementation that would happen up front, and that the model would ensure that there was access to services, particularly for historically and structurally marginalized communities that often are encountering barriers to accessing care and often are really looking to those community-based federally qualified health centers as their main access point for primary care, but kind of for all of the needs and supports for that. So for the first few years, we developed the model in collaboration with those original 3 federally qualified health centers. Right at the beginning of the pandemic, we actually spread to an additional 4 health centers. And so that middle test of spread happened throughout the pandemic, but fortunately we were able to successfully kind of test out spread of the model with those additional 4. And then about 2 years ago, we formally founded the Team Up Scaling and Sustainability Center. And now our work really focuses on scaling this model across the Commonwealth and increasingly actually across other states and regions as well. You can go to the next slide. So this is what we call kind of the Team Up transformation model. It includes both the clinical model, but as I was listening to Keri and Daley, I think one of the themes that you will hear as a consistent theme throughout here is we don't think of the clinical model as a standalone, but rather need to work on integrating that clinical model administratively and operationally across the organization as well. So a lot of attention to the operational fit and really focusing to make sure that works as well. So some of the kind of core characteristics are that the model is what we call a full spectrum model, meaning that it is really intended to be the backbone within the practice. It's there to serve 100% of the children coming into that practice, so from birth through young adulthood. It is also full spectrum in that unique to pediatric practices, we want a model that is not just focused exclusively on kind of diagnosis and then treatment at the point of diagnosis, but goes much earlier in that process and is looking to support healthy development, early identification of concerns or issues, way before there's a DSM-5 diagnosis. So full spectrum in that we're thinking about prevention, promotion of healthy development, through to identification of issues, access to care as quickly as possible, assessment, reassessment, and then linkages to community-based or school-based services where that's more appropriate as well. There's a core team that works together in that pediatric practice to deliver all components of the model. That is integrated behavioral health clinicians, but also integrated community health workers and those primary care providers. And then we at Team Up provide a learning community. And in that learning community, we're providing both clinical training and technical assistance that I'll go to a little bit in a subsequent slide. And then in the center, we also do a lot of kind of broad systems building work to support kind of the research and evidence base that supports integrated behavioral health care, as well as kind of supporting advocacy and policy that helps ensure that there's sustainability of that investment long after that implementation has happened. Next slide. So this is a little bit more about kind of how we conceptualize the whole care. We're really looking to take advantage of the opportunity primary care where primary care providers often hold the longest longitudinal relationship with those families and are kind of an entry point for a lot of different types of issues that come up. So medical issues, but also school-related issues, behavioral issues, developmental issues, mood-related issues. In Team Up, we do universal screening in all well child visits, so very consistent with the Bright Futures guidelines there. Use different screeners for different age groups, but do really use those screeners consistently in all well child visits. That leads to kind of a conversation with the family, with the patient, that sometimes surfaces identification of behavioral health needs, and then a warm handoff to that team. That's that engagement step. Then there's kind of that care planning step of figuring out with the family what the right kind of approach to care or services is, delivery of those services, and then we are looking to see improvements in health outcomes for those children and their families, and then ultimately improvements in system outcomes as well. We've been fortunate in Team Up that throughout our 10 plus years now, we have had a research and evaluation arm that has gone parallel to this implementation work to really build the evidence base that supports integrated care. And on the right side, you'll see just a very high level summary of those findings, which is indeed better outcomes for children and family, better kind of self-report of symptoms over time associated with seeing behavioral health clinicians at whole team and receiving access to care very promptly. Improvements in the workforce, how the workforce is identifying symptoms of burnout. We see that Team Up Health Centers kind of are doing better on burnout scales than national norms. And then better utilization patterns, better engagement in primary care, and actually just receiving behavioral health services within this type of model. Next slide. So this is a little bit more about what the Team Up Center does in our learning community. So we look to couple practice transformation support, so that, real concrete, operationally driven technical assistance with clinical training that supports everybody within that environment. So the behavioral health clinicians, the community health workers, and the primary care providers, because we think of it as everyone kind of shifting and working as a team requires some change and some preparation across all three roles. So it's not exclusively just training each of those roles to a specific skill set independently, but working with the whole team to be working together as a single unit. That practice transformation support includes, again, a lot of those operational supports. We do revenue optimization work with the practices, with billing specialists within those practices. Think through EMR functionality, how the EMR is working to help that whole team communicate well together, and then, kind of drive those changes, those operational changes forward, even beyond just the implementation period. Next slide. And then if we kind of take a step out from there, like a meta level, again, in the Team Up Center, we look to really do broader systems level work to sustain that transformation long term. So one version of that sustainability is ensuring that there is a ready workforce, there are policies in place that support that practice's ability to maintain that model after kind of funding for implementation has come to an end, that long-term sustainability. We have seen that even those early practices, the original 3 practices that we began with, have sustained this model even after their initial kind of 2 years of implementation. So do a lot of advocacy and workforce development work. And then also that research and evaluation work continues. For example, a portion of our evaluation focuses on looking at the all-payer claims data set here in Massachusetts, looking not just at comparisons around utilization patterns between Team Up Health Centers and non-Team Up Health Centers, but actually just building the evidence base that supports the rationale and reason why this integrated behavioral health is such a key component of looking for solutions that address the crisis in mental health that children and families are experiencing right now. So recently, for example, we published a piece that looked at just trends in behavioral health diagnoses that were being surfaced in primary care settings, seeing real increases, unfortunately, around anxiety diagnoses, continuation of the kind of core diagnoses that we would see come into primary care around ADHD, depression, autism spectrum disorder in particular. You can go to the next slide. So this is just like when we think in Massachusetts about our advocacy agenda, and then as we've increasingly worked in other states, we have found that there's real consistency across the core components of policy or advocacy areas. They may look a little bit different in different states, but there's some foundational concepts that I think are through lines throughout all of the different states that we've worked in. Here in Massachusetts, in our Mass Health 1115 waiver, we've been fortunate to see EOHHS and our Medicaid program move towards a more flexible, innovative approach that has different payment structures, tiers that support practices and thinking about bringing community health workers onto their team in particular, and just moving towards an integrated model. We look for ways to support parity of payment across different payers, commercial and public payers, really to streamline those operational processes and make sure that it's easy for practice to be able to access all the available revenue for the work that they're doing. We support kind of prevention, that there should be revenue available for all of the preventative work that this team is doing. And then a lot of work around advocating and advancing the CHW role is really a unique, distinct core component of making sure that kids can access care for mental behavioral health issues. And then I will just close with one final slide, just kind of showing the different areas where we're working with right now. So we have been fortunate to work with a lot of our partners here on this call as well in Rhode Island, and then also have a cohort that's beginning in New York and Georgia, and then doing kind of early work in South Carolina. Thanks very much. I'll turn it back.
Thank you, Anita. Linda?
Hi, good afternoon, everybody, and thank you so much for inviting me to be part of this great panel. So my name is Linda Cabral, and I'm the Director of Program Operations at CTC. Move on to the next slide. So we are a pretty unique organization. You go on the next slide, please. That is co-convened by our Medicaid office and our Office of the Health Insurance Commissioner. And we were convened in 2008 to really support primary care transformation, largely through the adoption of patient-centered medical home designation from NCQA. So as a result of that, we've kind of stayed in this primary care transformation space, and integrated behavioral health obviously is a core component of any advanced primary care site. All right, next slide. A lot of our work falls into these strategic focus areas. So some of our projects are focused on populations like pediatrics and maternal and family health, or geriatrics. And some are in cross-sectional in nature, like workforce development or data. Integrated behavioral health is something that crosses many of these sectors and many populations. So we are doing integrated behavioral health projects in both the pediatric space and the adult space. Next slide. So as far as a snapshot of what behavioral health looks like in Rhode Island, this is data from 2002, but probably not unsimilar to many other states on this call today. Many children are experiencing, major depression. In Rhode Island, it's about 14.5%. And less than half of them are getting any care for that. And so with the recognition that many of these kids are seeing their pediatrician or their primary care provider, that is the right space, the great space for screening and intervention to happen for behavioral health issues. We know that pediatricians are often that trusted provider with established relationships with the child, with the family, and is able to intervene and provide support around behavioral health needs. Next slide. So as has been mentioned by my fellow panelists, kind of when we see what does pediatric IBH look like, we're looking for universal screening to be taken place for both behavioral health and social determinants. We're looking for an IBH clinician to be embedded, ideally a full-time clinician on site, but given the size of many of our practices in Rhode Island, some of them are on the smaller side, it can be a challenge to employ an IBH clinician full-time. And so many of these clinicians are there on a part-time basis. And so having access to a clinician, whether it be full-time or part-time, is ideal. Being able to provide brief intervention, hopefully quickly while the family is still there. And these interventions typically can be one time or maybe up to like 5 to 10 times, but then anything that's going to need longer term support is usually referred on to specialty care. Right, next slide. So this timeline kind of shows a range of different pediatric IBH projects that we have undertaken since 2019. That's when we first kind of introduced the idea of what it means to be an IBH practice with pediatrics and provided some of that infrastructure support for the practices to get this off the ground. We were fortunate to have some health plan funding to allow CTC to provide funding to the practices to get some of the infrastructure components in place to make the EHR modifications, to develop new workflows, and also to support training and hiring of staff. And so once that initial foundation for IBH was established across many of the practices in Rhode Island, we were able to move on to other types of pediatric IBH projects, such as some of our ECHO series, which developed some community of learning around a particular topic, bringing in subject matter experts and case-based learning. And then I'm going to talk about and highlight a couple of our projects here today that are particularly I'm proud of with their innovative use of community health workers. Next slide. And so the DULCE model stands for Developmental Understanding and Legal Collaboration for Everybody. Is a evidence-based primary care model designed to improve healthy development of infants by integrating care coordination and legal advocacy into routine well child visits for the first 6 months of an infant's life. And it is something that is offered to everybody in a practice. It's not kind of targeting different populations and really utilizes a community health worker as part of a cross-sectional team. And I think that's one of the themes we're hearing today is really IBH really its core foundation is in that interdisciplinary cross-sector team. It doesn't happen in a vacuum. And so the community health worker, also known as the family specialist in this model, is the one kind of being that point person with the family to do some of these initial screenings and connection to services. Next slide. And so with this project, CTC was able to support the implementation of this model at various pediatric sites where the community health worker worked cross-sectionally in an interdisciplinary team to do some screenings with family, provide guidance, coaching for families, and intervening and providing resources when social determinants, health-related social needs were identified. Next slide. And so these are some of the data that came from that. So what we saw was, when the intervention happened, many of the visits, no-show rates decreased when families had this support and visits happened on time. And we know how important those first 6 months of life are and making sure those visits happening. And so families felt supported and were able to meet all the clinical guidelines that are established. Next slide. Right, and so the other project I'm going to talk about is one that involved many of the partners here today, including Hassenfeld and Team Up, and really sought to expand the role of community health workers on the IBH team. So many of the practices had an IBH clinician, a social worker, or a PhD trained individual who was providing the services and working with the PCP, but didn't really have that community health worker support. And so in recognition of the increased need that pediatricians were seeing in behavioral health and the decrease in capacity of staff, we wanted to introduce, well, what would it look like if we brought in a community health worker onto the team? Does that allow the behavioral health clinician to maybe focus more on the clinical side of things, and the community health worker to focus more on the care navigation and resource supports that is needed. And so we were really fortunate to connect with Team Up, who provided a lot of the clinical training for our community health workers and other members of the practice team to implement this model in 6 practices in Rhode Island. And these are our other partners in that work. Next slide. And so, as Anita mentioned, with this model, we're looking to have team-based care that utilizes community health workers in a collaborative way and a cross-disciplinary team, universal screening for anxiety, depression, and other health-related social needs, having strong workflows in place that really understand how warm handoffs happen and how handoffs to specialty care occur. And then other workflows like working with schools around early intervention or assessments that need to take place. We provided some help for the practices to think about workflows for that. Next slide. And so this is just some data snapshots that I'll share with you. So at the beginning of our project, none of these sites were screening that age 5 to 11 school age for depression and anxiety. And so by the end of the project, we had all sites at least working towards universal screening for that. Next slide. And then we use the MHAF, which is a practice self-assessment tool to help primary care and behavioral health organizations evaluate how well they have IBH in their practice. And so this is our pre and post measures along all of those domains. And you can see increases across all those domains. So their level of integration increased over the course of the 2 years. Next slide. So just to wrap up, as far as lessons learned, as I've iterated, it really requires cross collaboration between providers, behavioral health, schools, community health workers. And community health workers really are in a unique position to uncover barriers that providers might not necessarily recognize during a medical visit, things like language and literacy or difficulty navigating educational settings. And so that's a really unique component when that resource can be added onto project teams. It is necessary to provide some intentional education to the team about how to navigate with these new roles and how everybody can be working to the top of their license. While many practices were very enthusiastic about having the community health worker on their team, they just needed some guidance about how to involve them, what tasks they perform, and how it differed from what the social worker was doing. And then new documentation requirements take time when we're asking new screenings to be incorporated. How does that happen in the electronic medical record? When you are part of a large healthcare system, requiring IT support, as many of you know, things need to get into a queue. It doesn't happen overnight, and your level of priority for when this happens may be different than what you would like it to be. And so getting things up and ready, we need to make sure that we don't minimize how much time it's going to take to get that all in place. Next slide. So one of the last things I'll mention, and I'll wrap up, is around sustainability. And so when we kicked off the partnership with Team Up and getting those community health workers staffed up in those 6 practices, we had just in Rhode Island introduced a pretty comprehensive Medicaid benefit for community health worker billing. And we were kind of training up the providers about how to maximize that new billing code. And it was fee for service, which wasn't ideal, but at least it was a resource available. Unfortunately, that benefit was updated in 2025 and kind of provided, some less activities that were eligible for billing. Some of the collateral benefits that were eligible for billing were no longer benefit, like the case resource navigation, and some more limits on utilization were provided. And so as a result of that, there's a reliance on grant funding and thinking about how we can use advanced primary care payment structure, blended funding, value-based contracts to support this work and kind of right now there's a big reliance on fee for service, and there are some challenges associated with that. So for the sake of time, I'm going to skip through the last few settings, but happy to talk more about this as we move on to the panel discussion.
Thank you all so much. I think you can all agree that this was such a rich discussion, learning from all of your different initiatives, and thank you for doing such a thorough job. We touched on so many different things around the implementation of these models, lessons learned from engaging clinicians early on to implementing warm handoffs and workflows to support the work, thinking about integration of documentation into the EHR, and obviously talking about sustainability and scalability. And so I'm just looking at the time. My goal, as always, was to talk as little as possible in this. So I'm going to encourage anybody who has any questions to please put them in the chat. As they come in, I will ask just one question to get us going, but the goal is really to hear from our audience members. So please put in any questions you have there. And so one of the questions that we did receive previously from people as they were registering was just curiosity around how these models align or integrate with other community organizations and services that exist. So particularly around schools, mobile response crisis units, the 988 line as well. And so just curious if people can talk a little bit about how the model is not only integrated within the clinic, but it also interfaces with other sectors as well. I'm going to start calling on people for interest of time.
I'm happy to speak a little bit to that. I think one of the things that we try to do, and I'm not sure if I mentioned this or not, but similar to what Anita spoke about, the practice facilitation, many of our learning collaboratives and these projects that I mentioned in particular had somebody who provided technical support and kind of support around the quality improvement initiatives that were being expected of the practices as a result of their participation. And so things like educating the practice about the CCBHCs that are available in Rhode Island and how to leverage them, who their local CCBHCs are part of the practice facilitation that we offer them. So I think because of that additional resource that we have available as part of our learning collaboratives, that practice facilitator has a lot of knowledge about what are the different community-based resources that practices should be aware of and connected to. And oftentimes they're making kind of warm handoffs themselves, like, oh, you should really speak to the CCBHC in your area to understand how and when to leverage them to the maximum benefit for your patients.
I might just add on to what Linda is describing there and kind of just reiterating the importance of the role of the community health worker on the team. In the team up model, we do really focus and encourage practices to hire from the community that is being served, and ideally think about past experience perhaps in the school system or working with different community-based organizations. That role's ability to foster relationships with the community-based organizations and schools really, it's like kind of walking that final mile with the family. It takes a referral and makes it into a reality for that practice's kids to really be able to access those services. So that's been really important, I think, as well, around somebody in the model who really focuses on relationship development and maintenance with those community-based organizations.
I'm just going to echo that too. That's been a benefit as our clinicians, not only being from the community, but also reaching out to them in their position to hear about what's going on, what are new services that might be offered. I think a big one has to do with custody and forensic support. That's a big one in our population where they're always trying to make connections.
Thank you all. And Anita, you really hit the nail on the head with the CHWs. That was going to be my next question. I do see that one of our audience members, Kimberly, has her hand up. If you want to jump in and ask your question. Ask our audience members able to unmute themselves.
Let me try and
If
see.
not, if you want to put it in the chat, we can definitely circle back.
Yeah, Kimberly should be able to.
Perfect. I see Kimberly.
Hi, Kimberly. Can you unmute yourself and ask your question? Let's keep going ahead, Andrea, with other questions. We can come back.
Yes. And so a big area of interest was also around sustainability and scalability. And so Anita and Linda, you both touched on that a little bit. Anita, you mentioned that you've been expanding Team Up and now it has grown to other states. And so thinking about scalability, what advice do you have to states who are looking to scale up their models and expand?
Yeah, I think almost everybody who works in the Team Up Center has had some direct experience as a provider, either as a primary care provider, a behavioral health clinician, a community health worker, or kind of in a school system, something like that. And I think one of the things that we, from that vantage point, think is really, really important is funding actually to practices to give them a little bit of space to be able to focus on implementation of integrated care. And we at the center definitely do that. Linda's work at CTC Rhode Island, I think also we have been fortunate to be able to partner with organizations that have been able to kind of bring together some funds to give practices space to be able to do this work. Our goal upon completion of that work for full implementation of the Team Up model takes about 2.5 years, kind of in total, depending on your starting point. But we do really expect the model to be sustainable long-term, even without any additional funding coming in. Across many different states, the reality of today is that there tends to be funding available through your regular reimbursement structures to support the work that those integrated behavioral health clinicians are doing. As licensed individuals, they are able to bill for their services and receive revenue for those services, although I think lots of opportunity to continue to work on kind of full and complete revenue that supports all of the different activities, particularly the preventative activities that behavioral health clinicians are providing for those families. For community health workers, I think there's a emerging consistency around the distinct contributions that community health workers in similar roles make to access and delivery of behavioral health services, and a mixed bag of emerging ways that reimbursement happens. So in Massachusetts, there's not direct reimbursement for community health workers, but it is included in the tier structure around the subcapitation system in our current waiver. As Linda was saying, in Rhode Island, kind of some revenue, but perhaps some limitations on that as well. We found that to be true in New York as well. And while a little bit earlier in our work in Georgia and the South, some consistency there as well. So the other, I think, thing that we often stress is also when you're thinking about the revenue picture, the sustainability picture, to also include the wellness of your whole workforce and decreases in kind of turnover in your staff. We also know that primary care is increasingly kind of under duress with the requirements that go with being a primary care provider at this point. And a lot of folks are choosing to leave that field. And so our ability just to focus on kind of return on investment that's measured through wellness and sustainability of that workforce is another area to not forget about when we're thinking about long-term sustainability.
Thank you. And I do just want to highlight one comment that we got in the chat from Anna. She wanted to just flag the need to include commercial payers beyond Medicaid as we strive to develop a system for all children and not just children served by Medicaid. Absolutely. We have been getting some more other questions, some additional questions. So we touched upon this a little bit, the collaboration with existing outside organizations. So there is a lot of interest, particularly around communicating with schools and data sharing between like HIPAA and FERPA and how that works, how these models support that collaboration. So Daley and Keri, do you guys want to take a stab at answering that from your experience in your clinics a little bit?
I'm going to ask Keri to answer that one. How our clinicians work with schools in their care planning or in their treatment?
So the clinicians participate in meetings with the schools. They often are giving recommendations to initiate the process to have a 504, to get an IEP, or even to do testing through the school system, knowing that that is it doesn't cost money for insurance to pay for testing through school systems. They will participate in those. They will talk and consult with school systems, both on the teacher level and to administrative, to counselors. So there's a lot of collaboration, but a lot of it also has to do with building up the parents and being able to advocate for the needs. And there is direct training with families that the clinicians will do. So I hope that answers the question.
Yes, and thinking back to the implementation strategies, I think, like you said, training staff to reach out to community organizations and know who their point of contact is crucial. And so could you, I'm looking at the times, that's why I'm speaking really quickly. Could you briefly speak to the level, the amount of the training that goes on both for the IBH clinicians, but also for other members of the team, like the primary care providers, CHWs and case managers on site? Anybody who wants to take that question?
I also, thinking about the time, tried to answer the question in the chat around the community health worker training in the chat. But we'll kind of maybe supplement to say we take a transdiagnostic kind of common factors approach to the training for behavioral health clinicians. And working in an integrated environment is very different than working in a traditional outpatient type of setting. And so oftentimes we are supporting, kind of like not just the clinical skills, but also like the speed at which the primary care environment operates, and thinking through your diagnostic process and what you can do immediately to provide therapeutic support in that warm handoff, even if it's 10 minutes long or 20 minutes long. It's a kind of training around a much more flexible approach to how we think about kind of therapeutic support for the family. Generally, there's foundational training up front, and then we do case consultation on a monthly basis to focus on application of that training in your day-to-day environment and how you work through that on a day-to-day basis. For primary care providers, we train around kind of at a minimum first-line medication management for medicines associated with depression, anxiety, and ADHD. Again, with case consultation to support that long term. And then finally, we try to bring all that together. So thinking about kind of like, training opportunities that are focused on workflows, where all three members of the team are working through how that workflow is going to work together, so that they're thinking about how to best access and take advantage of their BHC colleague and their CHW colleague and their PCP colleague when they're working together on patient care.
Right.
And to add to that, the benefit of participating in a learning collaborative with other practices that are kind of going through this with you at the same time is that peer learning that also takes place. So with the opportunity to convene all the practices that are kind of doing the same thing, you're able to ask practices, how are you, approaching this? How are you getting this in Epic if you're on the same EHR? So I think that opportunity for peer-to-peer learning is a real valuable component of this.
Well, we are kind of right up at time. I just want to say thank you again to all of our panelists and speakers, to all of our attendees for hanging in there with us and for all of your excellent questions. Ash, I know you had one very quick announcement that you wanted to make, so I'll turn it over to you.
Awesome. Thank you. Speaking of peer support that Linda just mentioned, we want to encourage that more through networks convenings too. So all of us can share what's working well, what's not working well, and how can we improve and learn from each other. So we have an upcoming conference which is focused on children's behavioral health more on a workforce perspective. So it will be held on September 15th in Connecticut. So please feel free to register for the conference, and we would have more presentations about workforce over there. We would love to see you all join us and stay connected to know more about what network is doing, what webinars we are bringing up together. Please follow us on LinkedIn. And also wanted to thank all the panel members here for joining us today. And thank you, Andrea, for chairing this conversation so thoughtfully. This webinar will be recorded on our YouTube space, and will share all the slides and the email addresses so that you can personally reach out to all the presenters here. We hope that you continue to network further from this conversation, and thank you so much for joining us. Have a good day.
Thank you.
Thank you. Bye-bye.